All right, I'll turn things over to you all now.
Okay. So our case today is a 62-year-old female who came into the clinic for hyperparathyroidism. She is an active smoker, uses 1 pack per day, and does not use any alcohol or drugs. She has a past medical history of GERD, a hiatal hernia, stress incontinence, vitamin D deficiency, and osteopenia. Her physical exam was normal. If you want to scroll down just a little to the labs. All of her labs came back normal except for her calcium was on the upper side at 10.5, and her PTH came back at 266.5. And if you want to scroll down, I think to the next page, her DEXA scan was from 2016. It came back as osteopenia with the lowest score being a -2, and her FRAX scores from that. Her hip fracture at 0.8% and 6.7%, so not quite at osteoporotic yet. Her medications included Zyrtec once daily, vitamin B12, 1,000 microgram IM injections, diclofenac, 75 milligrams twice daily, isosorbide, 10 milligrams 3 times daily, oxybutynin, 5 milligrams twice daily, and Protonix, 40 milligrams twice daily. So the biggest thing with this patient was just looking at if she was a surgical candidate and when it was appropriate to start Sensipar.
Okay. Did you guys have a vitamin D on her?
Let me look.
Thank you. So I would say, just to kind of start while you're looking, can you scroll up to the top of her, or at least tell me how old the patient was too? I think you said it.
June of 21, it came back at 21.
21, okay.
Of 22, sorry.
So normally with primary hyperpara, what you will see is a high calcium and a high PTH. So it looks like she meets that criteria for, most likely she has primary hyperpara. But I also like to make sure like there's no secondary causes to even exacerbate the PTH elevation, which in her having a low vitamin D can probably just make this even higher on the PTH. So your criteria, first you have to establish the diagnosis, which it appears that she does have primary hyperpara. But secondly, you want to decide, like, is this someone who you would actually refer for surgery? So we have lots of guidelines that we use for this. So the things that I usually look through, and I can go through this on our slides, would be, you know, you want to look at the bones, you want to assess their kidney function, their age, what their GFR, creatinine clearance is, if they've had fractures in the past. So you look at those criteria and then can decide whether it's someone you would just follow clinically versus somebody that you would actually refer for surgery. So being that she's has osteopenia, I think the thing I would probably hone in on her would be is getting another DEXA scan to see if her bones have progressed because of this, and then optimize her vitamin D as well. So I would say if that she does have a DEXA that's now showing osteoporosis, or you have any evidence that she's had like fragility fractures, spinal fractures, then that would actually, she would meet criteria for surgery. If it's the calcium is high, but not too high. So like, let's say her bones look perfect and her D looks good, but you have the calcium that's still not at least 1 point over the upper range of normal, then you don't have to send them to surgery. You can just kind of follow that clinically. And I'll go over that in the slides, kind of what you would do to follow this patient. The other thing is that if you say you have someone who could be a surgical candidate, however, that they don't want surgery, for instance, or they're not a great surgical candidate, but they meet the criteria to have surgery, then you want to focus on like your endpoints. Like, what are you trying to treat? Are you trying to make their calcium a little bit better because they're symptomatic, or are you actually looking at like bone health? So that would be your target at the end of it. If you're just kind of doing medical management, you would either use the meds to treat the hypercalcemia, if that's the main issue, or treat the bones, or both. So I don't think she really yet meets criteria for cinacalcet to treat the calcium, but definitely if her bones are worse, I would treat that.
Thank you, Renee, so much for the feedback and recommendation.
Renee, I got another just follow-up question. If this DEXA scan had included the 1/3 radius and it did show evidence of bone mineral loss, would that be enough to be a surgical candidate, or where do you see the importance of getting that 1/3 radius?
Yeah, you actually, that is the criteria. So if you have osteoporosis at any sites, but lots of times the DEXA scans don't do that distal third radius. So when I order the DEXA, I will put on the order, like, please assess distal 1/3 of the radius, because that is one of the criteria for primary hyperpara is the distal 1/3. So yes, if it showed osteoporosis, I would refer if they're, willing to do the surgery.
Thank you.
Any other questions, Molly or Hugh, about the case? Or comments, not necessarily questions? All right, and any other feedback or recommendations from the group about the case? All righty. Well, thank you all so much. We really appreciate it again for the case presentation. Molly, you did a wonderful job, so thank you. And we encourage you to submit more if you want in the future. So thank you. I guess we'll move on to the didactic portion. If there are any questions about the case that come up later on throughout the session, we can always revisit it as well. We don't have to finish it right here, but for purposes of time, we'll go ahead and jump into the didactic now. Renee, I will go ahead and share screen. Just let me know when you'd like to go to the next slide. Thank you.
Okay, so again, as I said, I'm one of the nurse practitioners here in Endocrine, and so my talk today is going to be about more or less the asymptomatic form of primary hyperparathyroidism. Next slide. I didn't put this on there, but what I used are the guidelines and management of asymptomatic primary hyperpara. It was a workshop, international workshop. I got this article from the Journal of Clinical Endocrinology and Metabolism. So a couple of key points I just wanted to mention on when you're thinking about primary hyperpara. This is usually something that's an incidental finding. That's what I find mostly in my practice, is that it's being looked at maybe just on routine labs. You might notice a high calcium, or in someone who's being worked up for either osteoporosis or kidney stone. The non-parathyroid mediated causes of hypercalcemia are more associated with a low PTH rather than high. So that's a clue for you that if the PTH is low and the calcium is high, you need to look elsewhere. If you have hypercalcemia associated with a malignancy, you're going to see way higher calcium concentrations and the patients are going to be way more symptomatic. If we're looking into parathyroid carcinoma, you're going to see severe hypercalcemia with really, really high PTH levels, like hundreds to thousands. So it's not subtle whatsoever. And that's not something like we usually get referrals for because it's so uncommon, but just kind of keep that in the back of your mind. And then, long-standing asymptomatic hypercalcemia is more suggestive of a primary parathyroid case that's just subclinical. And if it's patients that are very young, that you might also consider a genetic condition called FHH. It's familial hypercalcemic hypocalciuria. Next slide. So like I said, the classic presentations we really see mostly are like bones that are brittle, fractures, kidney stones, hypercalciuria. I'm going to talk a little bit more in the next slides about kind of how we work those up. Next slide. And then the more non-classical ones that give you the question mark, like, what do I do with this? Is this an issue or not? Or the things like, well, actually, I'm skipping ahead a slide. Go ahead, one more slide. Sorry, guys. The variants of primary hyperpara are things concerned with primary versus the normal calcemic hyperparathyroidism. So in primary, like I said, it's most commonly asymptomatic, found incidentally in patients with stones. You're going to see a frankly elevated PTH with hypercalcemia. That's more straightforward. But some patients have just a PTH that's minimally elevated or within the range, but it's inappropriately kind of high normal, despite the fact that the patient's calcium is high. So like I said, you know, in a normal situation, your calcium's elevated, you should see a low PTH because it's trying to respond to that by lowering the amount of calcium in the body. And then we have situations that we see a lot that are called normocalcemic primary hyperpara, where usually that comes into play like you're looking at bone density or reasons to work it up. But you want to make sure that, you know, even though they have normal calcium levels, the PTH shouldn't be up. So sometimes we'll see like a high normal calcium with a little bit elevation of PTH. And also you want to make sure that you've ruled out reasons for the PTH to be up aside from primary hyperpara, like vitamin D deficiency or chronic kidney disease. Okay, can you go back one slide? I kind of went out of order. The classical things, like I said, bones and stones, but then we also hear about these patients who have the moans and groans. So I didn't put the abdominal things on here, but you know, some people will have like reflux, heartburn, irritable bowel symptoms, diarrhea. I've had one patient have really bad case of pancreatitis related to her hypercalcemia. But the ones that we can't like put our finger on and say, yes, that's your parathyroid that's causing it, is probably the most common I see is just like the mental fog, just reduced quality of life, sometimes depressive symptoms. The data is not real consistent, but it does show some patients might actually benefit from surgical intervention, and they will tell you, oh yeah, I didn't know I felt so bad till I had my parathyroid fixed. And then the cardiac stuff, there's not real clear data on that. The evidence is very subtle. We never use cardiac endpoints as a reason to do surgery, but some people suggest that there may be some link there, but nothing has been enough to make it be a reason to get a surgery. And you can go ahead 2 slides. So these are just some of the causes that can make your calcium be elevated, which the main thing I'm talking about today is the parathyroid mediated ones. But there are non-parathyroid causes like malignancy, if you're on very toxic doses of vitamin D, if you've had granulomatous diseases such as sarcoidosis, and probably one of the main ones would be diuretics. I see that a lot. You know, they're on chlorthalidone or something and they have hypercalcemia. But other things just to keep in mind, sometimes hyperthyroidism, and then there's a whole list there on the bottom right you can look over. Next slide. So secondary causes, as I discussed before, are the things you think about like kidney failure, CKD, low calcium intake, vitamin D deficiency, or gastrointestinal diseases where they have some malabsorption. Probably the top one on that is people with gastric surgery or gastric bypass surgery. Maybe something like celiac disease where they just don't absorb nutrients appropriately. In secondary, you'll see what will happen is that the parathyroid gland is appropriately responding to a reduced level of extracellular calcium. And then it tells your body to mobilize the intestinal absorption of calcium and bone resorption. Next slide. So again, thiazide. So what I usually do, some of the guidelines say stopping these meds about 3 months and then repeating labs, but by the time they get to endocrine, they've had it long enough. So I usually just give it a couple weeks and stop it. And Hugh, you might even be able to speak of this, but probably with the half-life, it probably doesn't even need to be that long. I guess I just kind of pick 2 weeks, make sure it's clear and out of the system, and then repeat the labs. Also, patients who may have like an underlying primary hyperpara that's not real a strong, it's more subclinical, it could actually be unmasked by the use of thiazide. So they could have a smoldering level of hypercalcemia and they just don't know it till they actually start the thiazides. I'm gonna find my drink. Hang on 1 second. My mouth's getting dry. What do I do with my coffee? Oh, here it is. Sorry, guys. So lithium is another one. It can actually decrease parathyroid gland sensitivity to calcium, and as a result might actually cause reduced urinary excretion, and you can develop hypercalcemia. Some of these patients get high PTH levels. If you could safely stop the lithium, you could actually repeat the labs afterwards, but I tend not to do that just because, you know, it's just, you have to coordinate that with psychiatry, and I don't think the benefit would outweigh the risk. I do have one patient who has this. We just are kind of following the levels. If her calcium starts getting up too high, we could always use cinacalcet to bring it down. So I haven't really done much with it. Next slide. So in order to diagnose the primary hyperpara, we have a kind of a set rules that we use. If you go to the next slide, this is kind of just like a table you can use to guide you. But the first thing I do is get a total calcium, but I usually use an albumin with it so I can do a correction, because this can be bound to proteins like albumin and might actually make the level look a little higher or lower than it actually is. So I put the formula on there. The guidelines don't recommend using ionized calciums normally. It's just sometimes those values or the assays aren't as reliable. So they do recommend just a total calcium with albumin. We use the second and third generation PTH assays, and then of course the 25 hydroxyvitamin D. I use that level to look at D repletion. If their Ds are low, which can be by itself the cause for secondary hyperpara, it could actually exacerbate the elevation of the PTH. So sometimes if you improve the vitamin D, you actually might get improvement in the PTH levels. Again, normocalcemic hyperpara, so you want to rule out secondary causes. Some of these people, just kind of run and have that normal or minimally elevated PTH. Other ones might actually progress. In fact, some of the patients, about a third of them, may actually progress to a fulminant case where it's not subclinical. Also, you want to think about patients who are really young or have chronic hypercalcemia like most of their lives, that there could be a genetic reason for that. And that would not be somebody you would recommend for surgery, because surgery is not the cure. Next slide. So this is kind of part of the last couple of slides on what you would do to work it up. And I included on there also, you could get 24-hour urine assessments for stone risk, but also for creatinine clearance and calcium excretion. Other options, of course, are the bone density test, PTH, and then some of the other tests like there are more bone turnover markers. I don't really use that in my guidance for how I manage this, but I guess if it's someone you're just treating osteoporosis and you might want to see these levels if you're trying to see how well the treatment's working, but it's not something I use for working this up. Next slide. So with the 24-hour urine, it's not always required to diagnose primary. It's really in cases where you might have like a normal calcemic hyperpara, or someone where you're kind of on the fence, like, is this primary or is this more familial genetic FHH? And about 40% of the patients with primary are really hypercalciuric. And about 75%, if you're kind of trying to find the difference, usually 75% of those with FHH have less than 100 milligrams of calcium out in their urine a day. So less than 100, that's kind of dictating like, oh, I think this is more like a genetic thing. I put on there your fractional excretion of calcium you can use. If you use that formula and your value is less than 0.01 and they're in a patient whose vitamin D is replaced appropriately, it's more suggestive of FHH versus over 0.02. It's more primary suggestion. Sometimes we'll do genetic testing, like those patients, like if the urine's maybe like 110 and you're like, okay, now what? So it sort of looks like FHH and they're kind of young and they've got a strong family history or multiple glands of parathyroids or hyperplasia, then you might want to do the genetic testing. Next slide. So when you're just planning on monitoring the patients, annually you want to get your serum calcium with albumin. You can do a DEXA scan every 1 to 2 years. If you're more concerned, your insurance with that diagnosis of hyperpara, they probably will cover every year. You want to look at, you could do x-rays of the spine if you feel like there's a risk for fracture. DEXA scanning, you can ask for the vertebral fracture assessment, but I don't think ours does that here. I think we've asked and they just don't do that. And that's just an assessment to give you the risk or assess for spinal fractures. I would usually get a GFR annually, creatinine. You can do a urine workup if you feel that they have had stones. You may want to get the 24-hour urine or the stone analysis. If you're kind of on the fence of sending this person to surgery, I usually go back and just do a good chart review, because a lot of times they'll have a CT on there or an ultrasound of some sort, or x-ray of the abdomen. And if you see stones there or any evidence of fractures, that would be a reason that you could refer. Next slide. So the guidelines for actually saying yes, they qualify. So if the calcium is 1 up over upper limits of normal, so like I think our upper normal range is, I don't know, say it's 10.3. So if it's 11.3, that would qualify. And then of course, osteoporosis on the DEXA, vertebral fractures, evidence on any imaging, creatinine clearance, or I use GFR less than 60, high urinary calcium output, or if you do like an X-ray or an ultrasound and you see any evidence of stones or nephrocalcinosis, which is just calcium deposits, that would qualify. And those who are less than 50. And the reason for that is they're going to be alive a long time, hopefully, and they're going to be dealing with this for a while. So the younger they are, the more exposed they are to like getting osteoporosis or stones. So you want to kind of get those patients seen sooner. Next slide. This is just a little more of that. You can slide over the next slide. Oh, I didn't mention also fragility fractures, so if someone falls from like a standing height or less and breaks something, that's considered a fragility fracture. But I also tell patients like, okay, if you were like 20 years old and a healthy young person, would you have broken your bone doing the same exact thing? So that's kind of how I define fragility fractures. Other part of the workup is a parathyroid scan. It's not ever used unless you've already biochemically established the diagnosis of primary hyperpara. So the only reason for doing this is that, okay, I'm going to refer the patient. We're going to help the surgeon assist them to see if we can localize a tumor. The problem is that like some of these, there's a lot of false negatives with these tests, so we don't ever use it to diagnose. But if you do have a positive scan, it is helpful for the surgeon because it can reduce your length of surgery. It can tell them where they need to explore. And that's an image of a parathyroid adenoma you can see lit up on the neck there. And that's kind of what the scan looks like. It's usually they place an IV, they give some radioisotope, and they take pictures. I think the test takes around 3 hours. They're not fully enclosed, so it's not like, hopefully with the claustrophobia, you wouldn't have an issue with this scan. Next slide. So surgical issues, I think the biggest, most important thing is that if you're going to send them for a surgery, you want to make sure it's in the hands of very experienced or expert surgeon in this. They do have nerves and vessels all around that area, so sometimes they'll do nerve mapping, but you want to make sure they're treated appropriately and you don't want to deal with any risks, hopefully. What else do I want to make note? So usually after successful surgery, bone density will improve over 6 months to a year, 2 years after. The evidence for fractures is reduced. Renal stone frequency should be reduced as well. And again, like I said, some people just have improvements in mentation and they feel a little bit better. In the surgery, they do help. They use intra-op measurements of PTH, and usually if they're exploring, say, on the right side, and they see the PTH fall about 50% over 15 minutes, then they feel that's pretty successful. Usually they'll draw blood on both sides to make sure the other side doesn't have any like hidden areas of concern as well. So there's the Sestamibi scan we can order. I don't usually order 40 CTs or SPECT CT. Sometimes I've ordered an ultrasound of the thyroid because you might find one in the thyroid gland itself or near it. But once I order the Sestamibi and refer them, I usually leave that up to the surgeon. They're just more expert and they know what they want and what kind of imaging they want to look at. So I don't usually order those tests, but they can be done. Next slide. So medically managing the patient is someone who doesn't meet criteria. They can be monitored very safely without surgery, and it can go over a period of years. So don't be surprised. You all really want to make sure you replace their vitamin D. Usually I start trying to get their Ds around 40 or 50, but the guidelines say you definitely want it over 20, maybe 30 is a little bit better. At safe doses, probably 1,000 starting a day. That should be pretty safe, and I just monitor the levels every few months, make sure they're coming up. You don't want to limit calcium because we know their bones are at risk for becoming more brittle, so you don't want to limit their calcium intake. They can use supplements, not excessive, of course, but I usually tell them try to get most of it through the diet. It seems to be a bit safer. There's all kinds of meds they can use to treat osteoporosis. Alendronate is one of them that could improve lumbar and bone mineral density. There's lots of other agents, but that's another whole discussion. The one to treat the hypercalcemia would be the cinacalcet. It actually acts by increasing the parathyroid gland calcium sensing receptor sensitivity to the extracellular calcium, thereby reducing the PTH. The big thing though, it's not going to improve bones. So like I said, if your goal is to help the bones and also you want to get the calcium down because they're symptomatic, you can do both. I mean, you can treat with cinacalcet and also gives them some kind of bone agent. Next slide. Okay, that's all, I guess. Anybody have any questions?
Thank you so much, Renee. That was wonderful. Any questions, comments? Melissa, I'm glad you're able to hop on as well.
Thank you.
I'll give it a long echo pause here. I wish I was a clinician, so I knew some questions to ask, but it's all very helpful. We really appreciate you, Renee.
Sure, no problem. Thank you.
And I'll absolutely pass along any questions that might come through via email as well.
Okay. Thank you for the nice case, Molly. You did a good job.
Yes.
Thanks.
All righty, well, thank you all so much. We really appreciate you all. And I'll echo what Renee said, Molly, that was a great case. And we thank you for submitting that. And you as well, Dr. Quinn. And thank you, Renee, for the didactic. Only announcement that I have is that the next session will be on August 24th, and Dr. Hayter will be presenting the didactic. So we hope you can all join that one as well. And we hope you have a great rest of your day. Thank you, everyone. Take care.